Hello, it's Jason Denbo, one of the hepatobiliary surgeons at Moffitt Cancer Center. Today we are going to talk about technical pearls from a robotic CAP-D portal lymphadenectomy. So it's important to generously mobilize the duodenum. This provides excellent access to the posterior area of the dissection, which is where a lot of these lymph nodes are located. You can see today we're really going to focus on what we call package number 5 and package number 6. This is the lymphatic tissue that is posterior to the bile duct and also posterior to the hepatic artery. Here there's a very generous mobilization because this patient had known biopsy-proven nodal metastases along the portal vein. Here you can see we're developing this plane between the lymphatic tissue and the nodes in the pancreatic head. It will become much more obvious to you here shortly. But here we're using the Maryland bipolar with a pinch burn technique. Here you can see the pancreatic head there in the lymphatic tissue. This lymphatic tissue was basically kind of surrounded and enveloped by a portion of the pancreatic head anteriorly and posteriorly. You'll see a little more of that later. But here we just continue using the pinch burn technique. We will use the vessel sealer at times, such as here. Now, double isolation of these structures really allows you to have controlled directional retraction that can be done either with the fourth arm or by an assistant. As you can see here, the distal bile duct and the common hepatic duct are all looped with the yellow vessel loops. Those clips you're seeing there are on the cystic duct. We're just showing you a portion of the portal lymphadenectomy today to highlight some of these technical pearls. And the part that is the most difficult and where most of the lymphatic tissue is located in these two regions. So here we're retracting the bile duct laterally, and you see the lymphatic tissue there. I think this is an important maneuver to dissect this off of the lateral aspect of the portal vein there. And you can see here the countertraction, the traction and countertraction being provided by the robotic instruments, and then the assistant pulling on the vessel loops really helps. Back again here to the portal vein. We want to dissect directly on the portal vein back towards the vena cava, which will allow us to really remove all of this lymphatic tissue. You can see that that's the cava back there. There's a little bit of blood and fluid that's staining it. You'll see it better later. And now we're pulling all the lymphatic tissue lateral and the bile duct medial. You can see that all that lymphatic tissue is completely detached from the portal vein. There you can see that posterior portion of the pancreatic head that I was talking about. These lymph nodes were intimately involved, but I was not going to leave any of those behind since we knew that they had metastatic disease within them. So that's really removing package number 5. Here, medial retraction on the hepatic artery allows you to see that medial aspect of the portal vein. And we really want to dissect right there on the portal vein to free all that fibroadipose tissue and lymphatic tissue so that we can remove all of it. Here you'll see a good picture here of you'll see the cava and the caudate lobe through the posterior aspect of this view. You can see it just continues to be pinch burn with the Maryland bipolar. These are the real working instruments when we do this, is Maryland bipolar and the fenestrated. The fenestrated, I think, provides excellent exposure and traction. You can see the cava and the caudate lobe back there through that window. And similarly to what we did lateral, medially here, we're just freeing this all from the portal vein so that when we do the counter traction and traction here, we can't injure the portal vein because it's already all been separated and we're pulling it up and off of the portal vein. There we added an additional loop to the left hepatic artery, the segment 2 and segment 3 branch. We're going to continue to use the pinch burn here, free it from the underlying surface of the artery, and like I said, majority of it has all been already separated from the underlying portal vein. You'll see the portal vein here again shortly. But you can see how that isolation of the hepatic artery really enhances this exposure. And you can pull it in different directions depending upon where you need to complete your dissection. There you see the portal vein directly behind that lymphatic tissue. You can see how it's been detached except from that superiormost portion. This here is what we have termed package number 6. It's basically all lymphatic tissue medial to the portal vein and just posterior to the hepatic artery. And then we take these out through using a glove. But you can see here, if we really you have to dissect on the portal structures, and that really enables a regional clearance of the lymphatic tissue. You can see there's no remaining tissue in there, it's just those structures. We're looping this so that we can use a bulldog to occlude it during the liver resection, which I'm not going to show you here. Here's some bonus coverage for you. This is just clearing all the lymphatic tissue overlying the hilar duct. Similar technique where you can see we're using the exact same instruments. Obviously here this right hepatic artery courses anterior to the common hepatic duct, which is not the most common, right? Most commonly it courses posteriorly. Here's ICG. I think this is a nice image here where you will be able to see the hilar duct and actually specifically the right and left hepatic ducts as we begin to free this tissue. There's typically not, like when the pathologists evaluate the specimens here overlying the hilar bile duct, typically there's not lymph nodes, and in this particular case there was one lymph node here which was actually negative. And there were 2 positive nodes in this case, which were, they were both in package number 5. The lateral package that we had freed off of the posterior pancreatic head. This case is actually for an intrahepatic cholangiocarcinoma. That's why we're doing the portal lymphadenectomy. But you can see here, I mean, that looks great, right? It's a beaut, Clark, it's a beaut. All the lymphatic tissue is gone. There's your ICG. Look at the hilar bile duct, the right and the left hepatic ducts. So in summary of the technical pearls, generous duodenal mobilization creates posterior working space. Double isolation permits control of those structures for directional retraction and exposure. Dissect the edges of the portal vein from the tissue packets, and really all the dissection is maintained on the portal structures. It should not be through the lymphatics. It's about regional clearance, not picking nodes. Thank you, and subscribe to the channel. See you guys later. Bye.